Good afternoon, Professor. Thanks so much for taking the time to take a listen to this video presentation for this week's assignment around around psychotropic drugs for children and adolescents. So let's get into it. First question, which SSRIs have been approved by the FDA for children and adolescents? There have only been 4 SSRIs that are approved by the FDA to administer for children and adolescents. They are Prozac for mood disturbance disorder starting at the years of 8 or above, or OCD, obsessive compulsive disorder, starting at the ages of 7 or above. You have Luvox, another SSRI, which is designed for obsessive compulsive disorder, which can be administered for children starting at 8 or under. You have Zoloft or Sertraline, which is another SSRI for compulsive disorder starting at the ages of 6 or below. And then you have Lexapro, which is going to be into the adolescent range starting at 12 or higher around mood disturbance disorder. And again, these 4 SSRIs are specifically made and approved just around major depressive disorder, generalized anxiety disorder, and children or adolescents, as well as compulsive disorders. It's also important to note that antidepressants, including SSRIs, have not been approved by the Canadian Health Organization for the treatment. So this is specifically for the U.S. FDA approval. So only 4 SSRIs have been approved. What other medications have been approved for children and adolescents? And then we're going to go into the conditions for which they are approved and the approved age ranges. This is going to be a more generalized, longer list as it does vary. So you have different levels of antipsychotic medications, first or second generation. For adolescents, you have, excuse me, you have an antipsychotic medication to treat for schizophrenia, to help with bipolar mania or autism. Age ranges for the schizophrenia is going to be 13 to 17 years of age. Bipolar mania is going to be anywhere from 10 to 17, the adolescent range, and then autism could start as early as 6, going into full adolescent area. From there, you have Haldol, which is, or haloperidol, which is the more common name known to help with Tourette disorder, behavioral disorders, schizophrenia, and acute agitation. They could start as early as 3 years old, depending on the individual. Other antipsychotic medications around bipolar disorder and schizophrenia include Orap, Navain, Trilofan, Isaprus, which again, all range from 2 years of age and up, or 12 years in age or below, really targeting the sensories in the brain to calm the nerve system. From there, you had a wide range of medications around stimulants. Now we get into the compulsive disorders, the OCDs, the ADHDs, Adderall, anywhere from 6 years and up. You have Ritalin, 6 years and up, and a different range of stimulants around, specifically more around ADHD. You have some medications here for anti-anxiety, which could begin anywhere from 6 years or below, or sedative muscle relaxer around 12 years of age or older. Again, more targeted generalized anxiety disorder. So from there, you would have Cirox, you would have Valium, you have Librium. And then finally, we're going to have some sedatives and hypnotics, which my assumption is you're probably going to need bigger approval and a more due diligent, thorough analysis of the patient before getting into the sedatives portion. And then finally, from there, what are the most important advocacy questions to ask your client and their caregiver regarding a child on psychotropic medication? This is an interesting question. My first initial reaction was thinking from the parent perspective, asking the professional, the therapist in this case. But I think it's really important to understand the necessities of the medication, understand their beliefs and feelings, since their child or the caregiver has seen the client on the medication, What were they like before? What was daily functioning like? What were the behaviors? What are they looking like now? Has there been improvement? What are their reserves? What are their cautions? And understand that there's a significant difference or correlation in a positive way or a negative way from when the clients were on these medications. From the client perspective, I think you really need to have a deep conversation just around their understanding of the medication, understand why they were given the medication, understand their own understandings of the illness or the root causes to be on this medication. How has it been for them? Get their experiences, get their feedback. And when we talk about advocacy specifically, has this medication been impactful for you in a positive way? Do you understand and see the benefits from this medication in itself? If you know someone or people who have similar symptoms or the same illness or disease, would you recommend this medication to those people to give a try? And I think that's the biggest indication there. Advocacy it's brand loyalty, but not being loyal necessarily to a pharmaceutical company or drug, but it is being able to explain how there's been a positive change and impact in your life around being on this medication and being able to see things and do things more and seeing it in a better light. But with that being said, some advocacy questions to really break it down. Is this medication working for you? Are you happy to be on this medication? What are the downsides or reserves you may still have that we can talk through? Would you recommend this medication to others if you were in their position, or if you were in the position of ability to offer this medication to someone? Would you recommend this solution? And if there are any additional questions or changes around this medication or treatment options, I think it's a good starting point to understand where their head's at, where they're feeling, and then from there you can really game plan with the client and or the child or caregiver around what the future looks like, if next steps need to be taken or not. And now we're going to get to part two. So as an MFT working with a child whose family or someone in the family is being treated for an attention disorder, first thing that comes to mind for me is ADHD, just attention deficit hyperactive disorder. We're going to reflect and respond to 4 different questions. What are the symptoms that are being medicated here? So for here, we're really focusing on the inability to maintain consistent focus, the hyperactivity and impulsive controls of movement, of speaking or acting out of turn, and really slowing down the oversensory cells and communications from the brain to the body and the body to the brain. So we're really working on the hyperactivity focus to really self-center them, to be more listening and also to be engaging at the same time without over-engaging or moving at 1,000,000 miles per hour, essentially. Really calm the nerves and calm the body. Drugs that are supposed to treat certain symptoms. So the first 2 drugs to me that come to mind is going to be around Adderall and Ritalin. Both of them are going to be stimulants. Both of them can also be administered at a younger age to children. I believe anywhere from as early as 5 or 6 years old for Ritalin. And for Adderall, it's going to be 6 years or up. And for adolescents, anywhere from 10 to 17 years of age. And of course, as we get older, the body grows, the body develops. You have to increase dosage if need be, though it doesn't say effectiveness has been increased as well. These 2 drugs are really specifically designed to target and treat overall mood from a million miles per hour moving, always excited or always feeling anxious and always feeling the need to say something or do something or get something out of their mouth and feel apart, which is, kind of like fear of missing out, but also not fear of missing out. Really controlling the hyperactivity behaviors, the anxiousness and the excitement of the body to feel like they need to do something or to say something. And they're really supposed to self-center the body and the mind to have them more focused upon one or two topics or subjects or conversations versus losing their attention and trying to have them focus on everything around them, close the window down so it can be more straight and narrow. And also just slowing down the brain activity and the stimulation that is going on, overstimulation and overworking of the cells and impulses shows in the behaviors and body movements. Has there been an improvement in the target symptoms since the child started taking the drugs? So, yes, there have been improved in symptoms. The child is not only more calm and can complete tasks that is given to them in the moment, they are more engaged as well as more ability to listen and speak within turn. Essentially, they can get more things done. They feel more productive and they don't feel as anxious to feel the need to partake or to be a part of a conversation or topic or activity that may necessarily not involve them or has no involvement of them at all. However, one of the common effects of Ritalin or Adderall is they are more zombie-like, would be the term that is given to us from patients and their caregivers. Though they are more relaxed and more calm, there are days where they are very slow, very zombie-esque. They seem very out of it. Sometimes their face expression just seems that they're not there, though they are. So it could be a possibility of lowering the dosage and really just kind of withdrawing some of the effects. It could have been too much to begin with, so now the brain and the body is going from super fast, super active, and now it's way into the extremities of super slower pace, and it seems like that they aren't with it and they're not able to stay on task, essentially, because of the change of pace within their body. So that is an everyday battle, give it conversation. So why would we continue the drug? If their mood has changed from excitement and happy to not depressed, but more quiet and just reserved, just because they're more leveled out. I can't answer that question for the parents why they should continue to have their child on the drug. The initial reasoning and the initial behaviors have been modified and have been alleviated, essentially. So they have helped. Best recommendation is to really consider lowering the dosage if possible first, and then go from there. And if we need to find an alternative medication that could still allow them to, be themselves, but just a notch or two lower of their regular selves versus 10. That in itself will be an improvement, and it will be a win-win. The child will still get the right treatment. The medication will still allow them to maintain a better just outlook, appearance, and mood, and an emotion, while their brain and their body is also slowed down enough to get the jobs done at hand. That would be my take. If it's not working, then you need to take them off the drugs, and we need to find a different solution at the end of the day. That's pretty simple. But I think just the biggest conversation is the drugs work or the drug works, but I don't like how my child or how this person is now. They just don't see themselves because of the medication. So it's a tug of war factor. But if it's not working, you take them off and find a different solution at the end of the day. Thank you so much for listening, and I hope you have a wonderful week, and we'll talk soon. Thank you so much.